Okay. All right. Well, hello, everyone, and welcome to the fifth in our series of 10 webinars that the Oregon Office of Rural Health is hosting, focused on critical access hospital finance and operations. Today's webinar is CAH Reimbursement Heuristic using Medicare Cost Report to reveal opportunities. I'm Sarah Anderson, and I'm the Director of Field Services at the Oregon Office of Rural Health. And I'm joined here today by another staff member, Stacy Rothwell, who is our Quality Improvement Program Manager. Before we get started, I'd like to go over a few logistics. Jonathan, if you could move the slide. The audio has been turned off and the video is also turned off for all attendees. Please select the ellipses on the right of your screen to populate the chat feature and use the chat to ask your questions. We'll monitor the chat for questions and ask them of our presenter, likely at the end of the presentation. You can also raise your hand by clicking on the hand at the bottom of the screen, and we can then unmute you so that you can ask your question live. The presentation slides and recording will be posted shortly after the session on ORH's website at the link on the slide, and I'll put that link in the chat in a moment unless Stacy's already doing it for me. So as I mentioned a moment ago, thank you, Stacy, this is the fifth in a series of 10 webinars that we're hosting focused on CAH finance and operations. You will see the next 5 webinars listed on the slide. And you can also find more information on the ORH website with the link in the chat. And with that, I am pleased to introduce our speaker with us today is Jonathan Pattenberg, who is a principal at Wintergreen. He's an accomplished, results-driven senior executive with nearly 20 years of progressively responsible experience advising for-profit, nonprofit, and government entities. Over the past 6 years, Jonathan has worked with entities ranging from independent practices to multi-state healthcare systems on how to leverage rural opportunities to improve financial and operational performance. Prior to that, Jonathan served as Chief Financial Officer and Chief Operating Officer for a 21-bed nonprofit critical access hospital. Welcome, Jonathan. Thanks so much for being here to share your expertise once again, and I'll turn it over to you.
Very much. Every time I hear that intro, it always sounds much better than it is. So hopefully I'll continue to leave up to those high remarks. As we talk through today, again, when we talk about the cost report, if you could take away anything from today's presentation, it's really around the framework that we have to start viewing our cost report as an operational document and not an administrative task that we look at once per year that we have to complete and submit to Medicare. Again, specifically for our critical access hospitals, this is a document that has a direct impact on the reimbursements that you receive for your cost-based payers. And the information that we enter into that cost report will directly impact those reimbursements that we receive. Now, when we look at a cost report, I always like to say it's merging the art and the science of cost report preparation. The science side is really where do you put the numbers and, do you have the appropriate expenses and so forth. The art side is all of the operational considerations that we must take into account as we start looking at that cost report. Again, where do our staff work? Do they float between departments? How do our providers engage employees? Do we have people working in the rural health clinic that are also working on med-surg and so forth? All of those different things you will not glean just by looking at extracted financial information that we give to our cost report preparers, or if we do it in-house. It's knowing all of those little nuances of having those providers bounce around or different things or where services are provided that will ultimately dictate the level of reimbursements that we receive. Now, I know all of you have seen this slide before, and again, I really want this to serve as the foundational slide for a lot of these presentations as a part of this 10-part series. And as we look at the different segments, again, everything comes back to that value to the community. Now, we've talked about the strategy components before, and today I want to focus more on the operational components. Now, when we break down and get into that, really the financial and quality aspects, again, even though they focus on distinct areas, we have to realize that they have a direct impact on one another. Now, when we start drilling in further, it's also the realization that how we are doing things from a quality perspective, from a revenue cycle perspective, and all of those different areas will impact and dictate how we categorize information in the cost report and how we will recover those funds going forward. Now, when we look at that cost report itself, again, it is a major component of that revenue segment of a critical access hospital. Now, again, all of the other components, the expense structure, the volume, the charge structure, all of those other components go into impacting that cost report itself. Now, what we don't want to do is we don't want to leave money unnecessarily on the table. Again, if we enter the information in the wrong box, or we don't categorize information correctly, or maybe we just carve out funding because we don't know where to place it, again, that can have a negative impact on our organization. We want to look at optimizing our cost report to ensure that we're receiving the adequate level of reimbursements for the services that we're providing. Now, as we go through the conversation today and have this presentation, it's really identifying those opportunities that will improve performance going forward. At no point will you ever hear me say we need to maximize the cost report or we need to base strategic direction on the cost report ramifications. Again, the cost report is a tool, and cost-based reimbursement is a mechanism of how we are reimbursed. We want to establish our operational performance and our operational position, realizing that the cost report is one component of many that impacts our reimbursements going forward. So if anybody ever comes in and says, oh, you need to change your operations to optimize the cost report, or you need to change this because you want to, maximize the benefit of the cost report, those are usually only short-term gains that will get you into a negative position in the long-term position of your organization. So again, you want to leverage the cost report to drive performance improvement. You want to leverage the cost report to improve your position. You do not want to base your organization on the cost report itself. And the reason for that is expenses change, revenue changes, volume changes, patient migration changes. All of these different things change, which will flow through the cost report. And you cannot make operational changes year over year to continue to maximize or take an approach of maximizing the cost report. So always think of optimize, not maximize. Now, what is the current landscape? Now, for us as critical access hospitals, because we receive cost-based reimbursement from a significant portion of our payer mix being Medicare, Medicare Advantage, and also many states Medicaid, we're insulated from many of the issues that our other PPS hospitals are experiencing. Again, as we experience cost increases, that flows through the cost report, and we will receive an increase in reimbursements from Medicare. Also, when we realize this, we also have to realize that there is a direct correlation between our expense structure and our reimbursements, and also our volumes and our reimbursement. So when we think about it to that degree, based on the highest level with how we're reimbursed as critical access hospitals, if our volume and everything remains the same and our expenses go up, we will receive a greater amount of reimbursements per unit of service. Because again, expense goes up, reimbursements go up. If we see an expense reduction, and again, volume remains the same, then we will see a reduction in reimbursements. On the other side of that also, if our expenses remain the same and our volume goes up, we're going to dilute down that expense over a greater number of services, which means our reimbursements from Medicare and cost-based payers are going to go down. Again, if our volume goes down and expenses remain the same, then our reimbursements will go up. There is always that titration back and forth between volume and expense structure relative to the reimbursements we're going to receive from Medicare. Now, what are many of the things that we've been experiencing as critical access hospitals, particularly as we come out of the COVID pandemic? Again, we've experienced staffing shortages, revenue cycle issues, outmigration, cost increases, service disruption. All of those are substantively impacting our organizations going forward. Now, when we talk about cost-based reimbursement, again, it's important to understand that for Medicare, even in a non-sequestration year, the best we can do from a Medicare is to break even on our Medicare business. Now, again, the original program of cost-based reimbursement for our cause was cost plus 1%. But again, what is 1% going to cover? So when we think about it to this degree, the best we can do for a critical access hospital for a significant portion is to break even as a critical access hospital. Now, on the impact side, from a revenue standpoint, again, it impacts our ability to how much revenue we can actually generate as a critical access hospital, because again, we can't make profit from that core business. Now, on the inverse of that, when we're looking at capital initiatives or expending on projects or doing certain things or bringing in an additional staff person, again, that cost flows through that cost report, and then we will pick up a percentage of that through that cost report going forward. So let's say we're going to spend $1 million on a capital initiative, and we're a 50% cost-based organization. Just by spending that $1 million, Medicare will pay us 50% of that cost, $500,000, over the depreciable life of that asset. And again, they will also pay us 50% of the the interest that we have to pay if we don't have the cash to secure that asset. Now, thinking about that going forward, also it has to remember that as we continue to expend or reduce our depreciation going forward, our reimbursements will continue to come down as we continue to go forward. So again, always that titration. Now, when we think about the economic philosophy of a critical access hospital, and the reason why I'm going into this in detail again is because as we start thinking about the cost report, again, the cost report is just a mechanism that impacts reimbursements going forward. It's important to understand the reimbursement mechanisms itself so that we can leverage that cost report going forward. Now, when we operate as a critical access hospital, we have to realize that there's an inflection point for eventually where we will turn from a loss position to a profit position. Now, we start with a significant amount of cost in a critical access hospital. And as our volume continues to increase, we're going to generate revenue, and eventually we will profit or cross a point where we will get into a profit position. Now, the biggest solver for us as critical access hospitals is volume going forward. I always like to say volume is the biggest driver to financial success for a critical access hospital. And volume is ultimately what will determine whether or not you turn a profit or lose money as a critical access hospital. Now, as we continue to go forward and past that profit point or that inflection point, we have to remember that even going forward, our profit position, carving out all of our non-operating revenue, our 340B, all of our supplemental, if we're getting PMPM or all that stuff, our profit is the difference between what we can drive down our reimbursements from commercial to our reimbursements from Medicare. So what we want to do is, by leveraging that cost report, we want to increase the spread between our Medicare reimbursements and our commercial reimbursements. Again, with commercial being on top, that is how we will continue to drive financial performance and improve our financial position. So long as we are receiving a greater amount of money from our cost-based mix, our Medicare payer mix, we are going to lose money and have to make up that margin elsewhere. And the reason why I emphasize this is I've been in conversations before where people are like, oh, we only want Medicare swing bed patients because they pay $2,000 and our commercial only pays $1,000. That is not how the cost report works when we think about it to that degree. Again, we want to know the nuances of the cost report. Now, it's important also to note too that operating at a critical access hospital, upwards of 90% of our cost is fixed and only 10% of our cost therefore is variable. So all of that cost, again, is set across those core services. Now, if we have 5 staff operating in our med-surg department and we're operating forward, it doesn't matter if we have 1 patient or we have 5 patients. We still need that nurse, we still need a provider, we still have our fixed cost, our facility cost, and so forth. As we increase our volume going forward, we're going to dilute down that cost per unit of service going forward, which then again allows us to get to that profit position. So if we have $1 million in cost and we only have 1 Medicare patient, Medicare is going to cut us a check for $1 million. Now that sounds great to that degree. Now, if we only have 1 patient and that patient is commercial, then we're not going to get $1 million. We're probably going to get a couple $1,000s, which means we're going to lose a significant portion of money. That is how the cost report works. Now, when we start talking about these performance improvement initiatives, and again, evaluating the cost report and looking at opportunities to optimize the cost report is only one of several performance improvement opportunities. We can see it's up in the operating aspect. Now, the reason why I always put the cost report in the operating component and not in the financial is because most organizations view the cost report as an administrative task beholden to the finance department. We have to get it out of that mindset, and we have to start operationalizing the cost report as a way to drive performance improvement going forward. So again, leverage the cost report and look at that as a way to go forward. Now what I'm going to talk about is I'm going to talk about several opportunities that we can look at leveraging the cost report as a way to improve performance. Now, again, Sarah just entered in the chat box that, again, if you do have questions around any of these topics, please don't hesitate to type your question in the chat box. We want to ensure that we can answer any of these questions going forward. Now, as we talk through the cost report opportunities, several of these opportunities, many of you came to realize as a part of the SHIP project. You know, we came on site, we did a lot of the SHIP projects this year in the state of Oregon, and part of that project included cost report reviews for many of the organizations as a part of those components. Now, as we talk through these opportunities today, again, these are some of the opportunities that you may have already come to realize. There's also additional opportunities as to how we can leverage the cost report itself. Now, the first opportunity is really around ED provider time studies. Now, if we were to look across the country, I would say this is the biggest opportunity for every critical access hospital across the country. In fact, if we were to look at all 45 states that have critical access hospitals, every state in the country could benefit from an improvement in the ED time studies. Now, what is the ED time study? Now, as a critical access hospital, because we are required to provide 24/7 provider coverage in the emergency room, Medicare will pay proportionally the proportion of cost relative to the Medicare patients to the non-Medicare patients for that standby time. Now, to calculate the standby time, we have to actually conduct time studies that calculates the amount of time the providers are with patients or do patient care functions with the amount of time that they're doing standby time. Now, I like to refer to it as the 3Ds for the provider standby time or the professional time. It's documenting, discussing, or delivering care. Any other time, it doesn't matter if they're sitting in the emergency room waiting for results to come back, or they're just hanging out talking to nurses, or they're just waiting for the next patient to come into the emergency room. Only the time that they're doing those 3Ds counts as professional time. Every other time counts as standby time. Now, even if you are waiting for results to come back, say you were to go in and meet with a patient in the emergency room, you send off for a bunch of lab work and an x-ray. Even if you are waiting in the emergency room for those results to come back, that transitions to standby time. Now, why do we want to get as much time into standby time as possible? The reason for that is, again, the more time we can get into standby time, the more cost that can be allocated to standby time. The more cost that is allocated to standby time, the more it increases our ratio of cost to charge, which then increases the amount of level of reimbursements that we receive from Medicare for providing those services. Now, when we look at the standby time versus the professional time, the industry benchmark is 20 minutes per patient visit. If you were to be 100% professional time as a critical access hospital, you would need over 26,000 visits per year to be 100% professional time based on 20 minutes per visit. So again, if you don't have 26,000 visits, you're going to have some proportion of standby time relative to professional time. And it pretty much goes down incrementally from there. So again, if you want to be 50-50, you need over 13,000 visits to be considered 50-50. Divide that in half. If you want to be 25%, you need to have 6,500 visits to be considered to that proportion. Now, looking up on the screen, this just looks at a hospital. And again, this hospital had 30 minutes of professional time with the industry benchmark being 20 minutes. If they were able to get back to a 20-minute benchmark, they would have added on $69,000 in cost to the cost report as an allowable provider expense. Their RCC would have gone up a 0.014, which would have improved their reimbursements, again, just from Medicare, $22,000. They also would have seen a gain in future years from Medicare Advantage, and they also would have seen a gain if Medicaid was cost-based reimbursed. Now, looking at it to that degree also, we want to continue to leverage this going forward. Now, I can tell you, looking across the state of Oregon, I saw benefits ranging anywhere from, organizations, a couple didn't have a benefit, up to well in excess of $150,000 a year by actually getting to a 20-minute benchmark. Now, when you talk to your providers, anytime you talk to a provider, they're going to say, oh, yeah, I spent all of this time with the patients and so forth and blah, blah, blah. Let's just be realistic. Again, it's the 3Ds: documenting, discussing, and delivering care. Now, when we looked across the entire country, again, the net benefit across the entire country was about $65 million for critical access hospitals that is being left on the table because they're not optimizing that. And in fact, when we look at the state of Oregon, we can see 23 of the 25 critical access hospitals, 92% of the critical access hospitals had the opportunity to improve their ED standby time and improve their net financial performance. So again, we want to look at this and we want to leverage this going forward. The next opportunity is around the consolidation of our rural health clinic cost reports. Now, prior to the Consolidated Appropriations Act of 2021, it was fairly easy for you to consolidate rural health clinic cost reports. Again, you would submit a letter to your MAC, you would say that you want to consolidate the cost reports, and then therefore you'd be able to consolidate the cost reports. Now, going forward, because of the Consolidated Appropriations Act, there is a limitation on the ability to consolidate cost reports going forward. You cannot consolidate clinics that were grandfathered with non-grandfathered. You cannot consolidate newly established clinics. However, there still is the ability to consolidate clinics that were established prior to 12/31/2020. So we want to look at that to that degree. Now, when we look at the consolidation of cost reports, there's several different benefits to consolidating cost reports. One, if we operate 4 or 5 different clinics, it reduces the administrative burden by consolidating and filing one series of M schedule cost reports, then having to file a separate worksheet M for each cost report. In addition to that, it also allows us to blend the visits of each individual clinic across the collective of all of the clinics. So if we have one clinic that's maybe missing the productivity threshold and the other 4 are meeting it, the visit threshold excess at the 4 clinics will cover the shortage of the other clinics. In addition to that, because we are all now subject to upper payment limits, if we consolidate, it could allow us to establish an upper payment limit under the higher threshold versus the lower threshold going forward. Now, up on the screen, we look at, again, 5 clinics that ended up consolidating. Now, they ended up consolidating those clinics, and by doing so, they gained about a $40,000 difference, again, just from Medicare, by consolidating those clinics going forward. Now, again, I've seen these benefits go far beyond $40,000. What I don't want to do today is I didn't want to throw something up that showed like a $300,000 gain because of looking at that going forward. So we want to look at, again, vet with our staff and vet with our cost report preparer as to whether or not we can consolidate our cost reports going forward. I did see a chat question pop up around the ED time studies, so I will jump back for a second and go into that. Now, there's different ways that we can actually conduct our time studies. A couple of the different ways are you can actually do a manual process. You can have a scribe or some individual follow around your provider and document how much time they're spending in each of those different functional areas. And again, you have to do that a certain amount of time every single month going forward to actually validate that and quantify that you're spending a certain amount of time. The other way is also to leverage technology. Now, the technology, the organizations that leverage that means going forward, and I like to call it, you could say it's kind of like low jacking our providers to that degree, is we're actually putting like a chip on the back of our provider's badge. And then each one of those rooms, we actually have a little module that then tracks the exact amount of time that that provider's inside that room with the patient. And then you can also leverage your EHR by turning on active documentation tracking and tracking things to that degree. So again, there's different ways that we can do those time studies. Organizations that do invest in the technological means, I would say get closer to the 15 to 18 minute time frame for the professional time. Organizations that do the manual are probably closer to the 18 to 22 time frame. Again, the benchmark is 20 minutes as to something we want to suggest. But again, if we're doing it manually now, and we're at, say, 23 minutes, and by leveraging technology, we can get down to 18 minutes or 17 minutes, the ability to add on hundreds of thousands of dollars in additional provider expense, the cost may be actually subsidized through the pickup of Medicare by actually leveraging that technology. Now, again, looking at that technology also, I do know organizations that have implemented technology that has also then been leveraged to actually track things such as their housekeeping carts and tracking things for allocation for other expenses. So usually once you get the cost in there and you get the technology in there, there's countless other ways that you can leverage that going forward. But nonetheless, doing your time studies and doing them effectively will allow you to improve that position. Please don't say that you are doing something right now where all you are doing is tracking either the amount of time the provider is in the emergency department or the amount of time that they are logged into the EHR. Also, Sarah has provided contact information. So even if you want to know what your hospital's estimated is later, please feel free to email me. I'm happy to calculate that for you quickly. It would only take you a few moments to let you know exactly how much time you are spending professionally relative to your emergency department visits. The next area really is around swing bed growth. Now, when we look at our cost report and we look at leveraging the cost report, every single critical access hospital, and it should not only be your CFO, it should also be your CNO, it should also be your med-surg directors, should know what your swing bed NF carve-out rate is. Now, your swing bed NF carve-out rate is the amount of money that Medicare subtracts for every non-Medicare, non-Medicare Advantage swing bed patient. And the way it works is Medicare says we are going to multiply all of those Medicaid, all of those workers' comp, commercial patients times that daily carve-out rate and subtract that from your fully allocated cost before they determine that routine rate. And your routine rate is that daily rate that you receive from Medicare and Medicare Advantage. Now, what we want to do is we want to leverage this rate as a strategic differentiator and a way to negotiate with commercial payers. And I'll tell you how it works. Let's say our routine rate is $1,000 per day. That's the rate that Medicare says is our cost-based rates. And I've seen these range anywhere from $800 up to in excess of $5,000. This is the rate Medicare will pay you per day for every Medicare acute care patient and every Medicare swing bed patient. Now, let's say our Medicaid NF carve-out rate is $250, and we're able to negotiate a $500 daily commercial rate to take a post-acute care patient. Now, Medicare is only going to ding us $250 on the cost report. Commercial is going to pay us $500, which means we are making $250 profit relative to the cost report impact. So what does this mean for us as organizations? I'll give you an example. This was an organization in New York. They ended up negotiating a $1,000 daily rate to do drug detox type services. Their daily carve-out rate was about $250. They were making $750 profit relative to the cost report impact. So again, we want to look at leveraging this going forward as a way to drive financial performance and improve our position. Swing bed growth also. We also want to look at how we can improve our swing bed performance. Now, up on the screen, this is just a quick way of looking at saying if we were able to increase our swing bed volume, it would improve our net financial position for the organization. Now, if we look, the swing bed had an average daily census of about 3.2. If we were to increase it only by 2, which is completely achievable, this would improve our net position by over $250,000 a year. Again, because the goal is to dilute down our average cost per unit of service by increasing reliance on the program. Most organizations, again, if you are operating at 11.9, you probably already have 3 nurses on per shift. So going to 13.9 probably would not require you to bring in additional care staff because you're looking at it to that degree. So again, we want to evaluate staffing plans. We want to look at opportunities as a way to drive performance improvement going forward and increase reliance on our swing bed program. Pricing methodology. Now, for critical access hospitals are in a unique situation. We want to specifically look at our cost report, and the worksheet we want to look at is the worksheet E Part B. And on worksheet E Part B, it tells us the proportion of the Medicare outpatient cost that is passed on to the beneficiaries in the way of coinsurance and deductibles. Now, the way it works for a critical access hospital is 20% of the outpatient charge is the coinsurance portion that's attributed to the Medicare patient. Does not matter if the cost is $1 or $50. Again, 20% of the charge is what's passed on to the patient. So what ends up happening is as we're establishing our price list, our charge description master, we want to ensure that we establish it in a way that does not put us at a competitive disadvantage compared to other providers. Now, I'll give you an example. Now, let's say we operate a rural health clinic, and we operate a rural health clinic that has a $400 charge under that critical access hospital's rural health clinic. Now, 20% of that charge would be $80 for that visit. Now, if this patient were just to go to a regular freestanding clinic or go to a PPS hospital and get those services, again, their copay may be $15, $20. At your facility, because it's 20% a charge, it's $80 per visit. Now, take this to other outpatient services, CT scans or MRIs or outpatient surgical services. Let's say we charge $2,000 for a CT. Now, again, if they come to your facility, $2,000 times 20%, $400 is the coinsurance cost for that patient to get to the CT at your facility. If they were to get it at another facility, again, they may charge the same $2,000, but it's not a percent of charge for a non-COP. So their copayment may only be $40, $50. Now, when we think about our patients in today's times in the price transparency realm of understanding where things are going, I personally would travel an hour to save, $350 on a CT scan if it meant that I would save that money going forward. So again, we have to establish our price list and we have to ensure that we're priced effectively within our market. Now, when we look at this, again, we've always established a threshold of 40%. So if greater than 40% of the cost is passed on to the beneficiary, we generally will flag that. Now, 64% on the high end in Indiana was higher than that 14% or 40% threshold. In Alabama, 19% are higher than that 40% threshold. If we go all the way out to Oregon, again, 38% of the hospitals in Oregon have a charge structure that is passing on greater than 40% of the cost to the beneficiaries going forward. So again, we want to look at our charge structures, particularly for those that are in a system environment. Again, if we're in a system environment, we want to look at regionalizing price lists based on the services that are provided throughout the region. Just because we can charge $2,000 at a 500-bed facility for a CT does not mean we should be charging $2,000 for that same CT at a rural critical access hospital. It has a direct impact on reimbursements going forward. Now, what are additional revenue cycle and additional cost report opportunities? Now, the first one is really around bad debt. Now, if we go back to the days where critical access hospitals used to receive 100% of the bad debt expense for their Medicare patients, we used to be able to operate in an environment where we really didn't have to push as hard our bad debt policies. Now, because critical access hospitals get the same 65% as all other hospital entity types, we have to establish bad debt policies. Now, the first thing we want to do is we want to ensure that if claims are not collected, we send them off to a collection agency to try to pursue those claims. Now, if a certain amount of time passes and that collection agency was not able to have any progress on the collection of those claims, we want to pull those claims back, deem them as worthless, and then include them on the cost report. Again, so we get that percentage back from Medicare. We cannot include claims on the cost report that have not been deemed worthless and pulled back from the collection company. So long as anybody continues to try and collect on those claims, we cannot include those going forward. Now, what do we want to look at as processes? Again, we want to implement processes, again, operationalizing the cost report and using it as a way for checks and balances. We want to operationalize a process that says, if a certain amount of time has passed and there's been no movement on that claim, let's say 90 days, we're going to send it to a collection agency. Then if another, 120 days has passed and there's been no action on that claim, we're going to implement that process so that it automatically comes back to us and we're able to then deem it as worthless. What we don't want to do is we don't want to rely on our collection companies to send claims back to us. We want to implement a standard that automatically drives that process going forward. Now, we talked a few moments ago about the charge master and the impact of that on organizations relative to the proportion of cost that's passed on to the beneficiaries. Now, another worksheet we want to look at is really worksheet C, and this drives or presents our ratio of cost to charges. Now, the ratio of cost to charge looks at the proportion of cost relative to our charge structure within our hospital. Now, when we're looking at our ratio of cost to charge, what I can tell you is anytime the RCC, that ratio of cost to charge, is less than 1, your charge structure or the charges for those services is higher than the cost to provide those services. Anytime the RCC is greater than 1, then the charges for those services or supplies is less than the actual cost for providing those services or supplies. And then if it's exactly 1, which is a rarity but does happen, then your cost and charge is exactly the same. Now, when we look up on this screen, the reason why we can actually leverage the RCCs on the cost report is because it can tell us if we are disproportionately charging for certain supplies that is an outlier or services to the rest of the services. Now, if we look up on the screen right here, we can see that respiratory therapy is a 0.01. Now, when we look at it to that degree, we can see that if we were to look at it to that perspective, our respiratory therapy, the charge structure is over 15 times higher than the actual cost to provide those services. So we are charging a significant amount of money to provide those services. Same thing with diabetes education or intra-IV therapy. Again, 0.05, 0.01. Again, we want to ensure that we're pricing appropriately. Now, on the inverse of that, this can also allow us to determine whether or not we are missing charges or we don't have an adequate amount of volume to drive a certain program. Now, again, I would never decide to get rid of a program just because we don't have the charges, but it's important to understand, are we dedicating mission dollars to support a specific program or service? Now, one of the most common ones, particularly in rural hospitals that are in systems that we want to pay attention to, is medical supplies. Now, if we look up on the screen, we can see that medical supplies has an RCC of 1.037. Now, what this means is that we are not charging enough for the supplies that we have to actually cover the cost of those supplies. Now, there's a couple different reasons that this can happen. One is maybe we're not actually updating our supply list and charging for all the supplies that we could. Another instance, oftentimes, particularly those that are in a system environment, is you may set a threshold of $20 or higher for chargeable supplies, or $50, or whatever the case may be. For critical access hospitals, we want to establish a lower threshold because, again, we want to ensure that the charge structure is appropriately applied across the different payers that are using those supplies so that we can get reimbursed from Medicare for the proportion of supplies spent on their patient population. So again, oftentimes with critical access hospitals, we will see a supply threshold as low as $5. Now again, the $5 is after markup. So take your supply, if it's $2, mark it up 2.5 times, you get to $5. So it's not a $5 cost that you then mark up to $20. Again, it's a markup number that you look at. Now, again, in today's times, you may want to set that at $5, at $10, but nonetheless, the lower we lower that threshold, the more supplies we're going to be charging for to that degree. What we don't want to do is disproportionately pass on costs to things such as surgical services or outpatient services or whatever the case may be, and not get adequately reimbursed for those services if a significant portion is attributed to Medicare patients. The next big area we want to talk about is overhead allocation methodologies. Now, this is on the B-1. Now, when we look at our cost report and how we figure to operationalize our cost report, talk about a tongue twister. One of the biggest opportunities is looking at the stats used to step down overhead cost. Now, there's several different departments. You have your depreciation expense, which is based on square footage. You have medical records. You have nursing administration. You have G&A, which is step down based on fully accumulated cost. You have dietary based on meals. Again, depending upon how big your organization is will dictate the number of categories that you have to step down. Now, all of those overhead expenses step down to your revenue and non-generating or non-reimbursable cost centers within your hospital. So again, all of those departments step down. Now, what happens on those different stats is we want to ensure that we are regularly evaluating those stats to ensure that they're updated based on current operational considerations. For instance, maybe we have somebody that ended up vacating one of our primary care practices. They were leasing space, and now that's vacant space within the hospital. That is now considered non-reimbursable cost space. Again, can we leverage that as A&G? Can we turn it into some other service line that allows us to leverage that space? Or maybe we did a capital initiative within our hospital and we never updated the square footage. All of these things will directly impact our net financial position and our reimbursements received. Medical records, again, most hospitals will use gross charges, which granted is the easiest way to actually allocate medical records. But again, when we think about it, where is most of the time spent in medical records? Is it spent on diagnostic imaging and laboratory, or is it spent on surgery and emergency room and inpatient services? Again, we want to look at time studies and things to that degree as a way to look at stepping down costs. Nursing administration, again, many organizations will put all your floor supervisors in nursing administration and then step down that way. Again, nursing administration should generally only step down to the departments that require direct nursing supervision. Now, these are just a couple of the examples. We definitely want to be looking at our stats and how they are stepped down. It will have a significant impact on our reimbursements going forward. Also, when we look at our stats too, we want to make sure that things such as square footages and things to that degree that we're evaluating annually to ensure that our square footage numbers are accurate going forward. The next area is really around interest income. Now, as critical access hospitals, again, because we receive cost-based reimbursement proportionally to our Medicare payer mix, the way it works on our cost report is the interest flows through the cost report as an allowable expense. Unfortunately, the way Medicare looks at the cost report is they say any interest that you earn, interest income or investment income, is subtracted from interest expense. Because again, if you have money to set aside that you can invest and earn income, why should Medicare have to pay interest expense when you're making profit on money that you're sitting there and holding? There is an exception to this with a board designated funded depreciation account. If your board actually sets aside funds in a board designated funded depreciation account to fund future capital initiatives, the interest earned on those funds that are set aside is not determined or used as an interest income offset to the interest expense. So again, this is not something that's permanently restricted. It's not something that is held. It's not something that is taken away. This is something that the board can regularly put funds in, and if an emergency arises, pull funds out. But again, we want to do our due diligence and look forward and set aside funds and not lose out on reimbursements by having a ton of money just sitting in a short-term investment account or a long-term investment account without trying to set aside funds for future capital initiatives. The next area is around method 2. Now, critical access hospitals, again, I'll explain what method 2 is really quickly. Method 2 is an election or an option available to critical access hospitals. Now, what method 2 affords you the ability to do is it gives you the option to file a single consolidated claim on a UB that includes both the professional and the technical component. And by filing that consolidated claim, Medicare has come out and said, we will give you an additional amount on top of the pro fee revenue by filing that consolidated claim. Now, only critical access hospitals can pursue this. Now, even though critical access hospitals may pursue this, we still want to ensure that, again, our cost report is accurate in tracking that information appropriately. There is a certain line in the S2 that says, have you pursued or elected the alternative reimbursement methodology afforded to critical access hospitals, which is that method 2. If we are pursuing method 2, we want to make sure that we put a yes in that box. If we are not doing method 2, this is something that applies to all of our outpatient services. So again, it can provide to our diagnostic imaging for our radiologist, emergency department, provider-based clinic, Again, all of those outpatient services, we can elect to pursue that method too. Now, it does not apply to our rural health clinics because they get an all-inclusive rate, but it does apply to those other outpatient services. Also doesn't apply to rehab services because, again, that flows through the RCC and you get reimbursed that way. Now, the other thing that we can also leverage our cost report for is determining general profitability of departments. Now, oftentimes we will go in and look at a cost report and look at the reimbursements that they receive from Medicare versus the reimbursements that they receive from other programs. Now, up on the screen, I highlighted an example of home health. Now, again, I'm not saying to get rid of any of these programs. It's important to have an understanding, and we can leverage the cost report as a way to drive that going forward. Now, this is an organization that had a home health program with $1.6 million in fully allocated costs. Now, when I say fully allocated costs, that includes the step down of all of that overhead expense. Now, there were 7,400 visits, of which 2,245 were Medicare. Now, Medicare reimbursed them $420,000, average of $187 per visit for those 2,000 roughly visits. Now, when looking at a margin position based on the fully allocated cost, this organization would have had to receive $231 for every non-Medicare patient to cover the cost of that home health agency. Now, again, not saying to get rid of that program, we just want to evaluate that going forward. I've seen some instances where they would have had to recover $500-$600 for the non-Medicare business to turn a margin on the home health program. So again, we want to leverage the cost report going forward. Now, when we also look at the cost report, we have to look at it through the lens of those operational components. Now, as we talk through today, again, I highlighted certain opportunities and certain ways that we can leverage the cost report. This was really a starting point to start to get us to dive in and look at the different ways that we can operationalize the components of how we can leverage that cost report going forward. Now, again, these are common themes seen across many critical access hospitals across the country. When you drill into your specific cost report, you may see additional opportunities. For instance, if we look at our D Part V and we can see that there are no charges dropping for physical therapy, maybe we have charge capture issues. If we look at certain services and we can see that our RCC is super low for our provider-based clinic, maybe we're including our professional charges in our technical charges for the cost report. Again, the cost report is not only an operational document that we can leverage to drive revenue going forward, it is also a document that we can leverage to actually assess and individually audit our current position and how we can actually step things going forward. Now, taking this one step further, and then I'm going to stop and allow anybody to ask questions, you can also leverage the cost report as a way to drive more accurate financial statements for all of your different departments. Now, as I mentioned earlier, the B-1 gives you all of the different stats and the step down of overhead, the A&G, nursing admin, benefits, all of those different departments. Now, after you calculate all of those different departments, the B Part 1 actually tells you what the fully allocated cost and the overhead allocation is for each one of those different departments. So you can actually leverage your cost report to do overhead allocations within your individual hospital to give more accurate financial statements to the different department managers. So again, they have a better understanding of what their fully allocated cost is and looking at what they're actually contributing to the bottom line performance. So there are countless different ways that we can leverage the cost report going forward. Please do not just look at it as an administrative financial task that we have to complete once a year. Please start looking at it as a living document that does have a direct impact on your financial performance going forward. So I'm going to pause now. Again, I know I went over a lot of different things to see if there's any additional questions, or even if there's just a general cost report question that maybe has been vexing you that you just wanted to throw into the chat box.
Thanks so much, Jonathan. That was a really great presentation once again. So we are going into the question and answer period. Please feel free to put your questions in the chat, and we'll make sure that Jonathan answers those. You can also raise your hand at the bottom of the screen. So Jonathan, I have two questions here. The first one is going back to method 2.
Yes.
And wondering generally what you see that improving reimbursement rates by. Is there a certain percentage? Is, they're kind of an example of um, the amount of revenue that's generated by that
Yep.
versus the regular method?
So I would say in a worst case scenario, generally it's going to improve your reimbursements 12% on fee schedule for those outpatient services directly attributed to Medicare. Again, Medicaid doesn't recognize method two, so it's attributed to that Medicare side where you'll pick up 12% on fee schedule. So if you have your emergency room provider, and let's say the reimbursement rate is whatever, $350 for 99215. I know that's high, but anyways, for that 99215, you would pick up that 12% on that professional component for that one visit from Medicare. And again, so I mean, when you think about it to that degree, if you have rural health clinics, you already have the ability to file consolidated claims that include both professional and technical, because you have to do that for the rural health clinic. So implementing that across your critical access hospital would be pretty easy to that degree because you're just going to build it across other departments.
Great, thank you. And going back to the consolidated cost reports for provider-based clinics, just kind of a technical question here, but you had shared that great map earlier when you were talking about, let's see, was that, it was the slide before, but at any rate, we're wondering if there is wait, yeah, that one for the ED. Is there a
Okay.
similar data for RHC cost report consolidation that's available? And kind of looking at that from a, kind of peer-to-peer perspective where folks might share those strategies across the state.
We have, there's no national data relative to the cost report consolidation. Um, Next week, Thursday, I will be presenting at NRHA in San Diego, and we're actually looking at the net impact to the Consolidated Appropriations Act. So how much money did every state actually lose? I guess some people made some money, but overwhelming majority, how much money did every state lose because of the Consolidated Appropriations Act of 2021? So I can tell you across the country, I think it was a loss of $28 million actual experienced loss. By the time it gets to 2028, we're going to be pulling $370 million out of rural because of the Consolidated Appropriations Act. And actually, the distribution is worse. It's actually about $500 million from our PBRHCs. So all of our critical access hospitals, all of our fewer than 50 beds. And then we're adding about $170 million for independents in the greater than 50 beds. I know that's not the question you asked. That's the analysis that I've completed right now that will be coming out next week. We usually do the consolidated type things after, but first we just got the release of all the HICRIS data for 2021. So that was the first level of analysis that I had to get done just because I'm presenting Thursday. And then we'll jump into the other components and start rounding out the rest of the things.
It's interesting. That's quite a big impact.
Yeah, and I mean, when Congress came out and said, and I don't want to get into the politics, but when they said it was budget neutral, the fact that the overwhelming majority of RHCs in the country are provider based, and they also have significant expense structure, I just knew when it passed it was going to be a negative impact. And frankly, I did a preliminary analysis a year ago that kind of looked at non-historical or non-actual 21 numbers and kind of projected based on historical increases. So it's actually worse than that because the cost experienced by all clinics, and you're all operators, I mean, you've all experienced a greater than 2% increase in expense in the last year. I mean, nobody's kept to 2%. So every year that you go up higher than that MEI, it's only going to be negative for longer.
Yeah, thank you for filling that in. That was going to be a follow-up question that I had for you.
There's actually there's two things to look at for the RHC. One is, can we consolidate? Did we consolidate? And the second one is the lost opportunity for those that did not file their waivers. So in 2020, it was your starting point for every cost report year thereafter for your grandfathered RHCs. So that year is disproportionately higher in relevance than any other year because if you did not file the waiver in a year where you were in the middle of a pandemic, your rate is artificially lower than it should be. So let's say you should have had 20,000 visits, you only saw 10. Your rate is 50% lower than it would have been if you had submitted that waiver that's now locked in and trending forward every year thereafter. So there's also significant loss on that also that I plan to finalize the analysis on that also to kind of let people know, because again, that's something that the pandemic drastically impacted organizations. They should not be locked into loss for years to come.
Yeah. Huh. Interesting. We have another question. Someone who's asking if you have any thoughts on the rural emergency hospital designation, particularly for CAHs that are part of a system and that may have the opportunity to shift lost inpatient volume to an affiliated PPS hospital.
I have a ton of thoughts. No, I mean, in all seriousness, I mean, you have to, there is no one size fits all. There is an environment where the REH will work. But what I will tell you is that a quick way to kind of look at it to start is if the amount of money that you're getting from Medicare now is greater than the administrative payment that you would receive as an REH, you're probably doing better now. And I'll give you an example. I looked at, you have some massive CAHs out in Oregon, $100 million plus facilities. The REH would probably not work for any of those facilities. I did one for a critical access hospital in Virginia where we looked at them, and it's about a $45 million CAH. Converting them to an REH would have actually lost them $6 million a year. So what people don't look at, and particularly in our systems, is they're going to say, oh, well, here's an REH. Let's just flip it to outpatient services. We're going to funnel all of the inpatient volumes back to the system and everything's going to be great. What they're not looking at is the amount of overhead that is covered through that inpatient unit in your swing bed by actually having cost-based reimbursement, because your swing bed is like 90% cost-based, your inpatient unit. So your inpatient unit as a whole is probably 60 to 70% cost-based. That's pulling down a ton of overhead, depreciation that's flowing through that cost report. So I would just do your due diligence and make sure that you evaluate correctly. Now, if you're a $4 million critical access hospital, I don't think you have any of those in Oregon. But if you were a $4 million critical access hospital, net patient revenue, and Medicare is going to give you a check for $3.2 million just as an admin payment, that I would probably look at converting, because you're going to make more by literally doing nothing than you're making now when you add up all the services. So just do the due diligence. I will tell you that it is a complex model to go from CAH reimbursement back to PPS, because you have to go back to APCs, you have to do all of that stuff. It's not an easy analysis. So just make sure that if somebody's calculating it, that they know the differential between CAH and PPS to do that analysis.
Great, thank you. And to the person who asked that question, and for everyone, on the same website that's in the chat where this webinar recording will be posted, we have resources related to the rural emergency hospital listed on that same page as a accordion dropdown. And there is a technical assistance center for rural emergency hospitals on that page that can answer specific questions and really get into the technical details as well. So with that, we are out of time, and really want to thank Jonathan again. Jonathan, if you can go to the next slide, that would be great. Before we get into ORH announcements, when you leave this webinar today, a survey will automatically pop up. We really hope that you'll take that survey, because it helps us improve our programs, and it also makes you eligible for continuing education credits as well. So you have that option in the survey. So a couple of notes. Next week already, we have our Forum on Aging in Rural Oregon and our Oregon CAH Quality Workshop, both of which will be held at the Seaside Convention Center, May 15th through the 17th. The links on these slides, which are posted on our website at the link in the chat, are available. You can register still. and we hope to see you there. And then lastly, our next webinar in this series focused on CAH finance and operations is 10 CAH revenue cycle priorities, what to review immediately. That will be held on June 8th at noon. And with that, I would like to thank everyone for attending. Thank you, Jonathan, for your time, and we will close out now.
You're welcome.